دكتور جمال نقدر نبتدي دلوقتي بعد إذنك اتفضل.
Good evening. First of all, I would like to thank Hygiene Company for supporting this scientific event and the support of the Egyptian Orthopedic Association. أنا في الأول طبعا بشكر شركة هايجنت على دعمها المستمر لجمعية جراحة العظام المصرية والدعم المستمر للأنشطة العلمية. I'm going to speak about a very important topic, the deformity. People may think that deformity is drawing lines and correcting these lines. This is not true. We have clinical aspects, very important clinical aspects. The concept of a weight-bearing axis is not new and is usually termed the mechanical axis. As you see here, this is the mechanical axis. It's not new, it's very old. It's depicted as a line passing from the center of the ankle to the center of the hip, from the center to the center. And it represents the path of the transmission of the load-bearing force relative to the lower extremity. So it's representative of the path of the transmission of the load-bearing force relative to the lower extremity. Normally, this line from the center to the center, from the center of the hip to the center of the ankle, passes through almost to the center of the knee. In cases of deformity, if it passes medial to the center of the knee, that means we have a varus deformity. And if it passes lateral to the center of the knee, that means we have a valgus deformity. Another important issue is that the expressions, the user use the term CORA, ACA. It seems like difficult terms, but this is not true. We don't do something new. We dealt with deformity for decades. CORA is called center of rotation of angulation. But remember, long time ago, when we were treating fractured lower fourth radius, we were doing flexion, deflection to correct the deformity. So if you see here that we consider the site of the fracture and the deformity of the fracture as a deformity. So this is the CORA, or the apex of the deformity. And we put our two thumbs, distally and proximally, to correct the deformity. And in between, we create a hinge or a ACA. So we use a hinge, we use the CORA, and the fracture, the osteotomy. So actually, nothing new. It's just we try to standardize the language of the deformity. Again, wedging the cast. It's exactly how we deal with the deformity. In this situation, we have a fracture and we have a deformity. And we do wedging cast. You see here the fracture, the site of the fracture. When we do the wedging cast, we don't do it exactly at the site of the fracture because we consider the fracture as a deformity. So we deal with the fracture as a deformity. We project the axis of the distal tibia and we project the axis of the proximal tibia, and they meet each other not in exactly at the site of the fracture. And we build the fracture site at different areas from the site of the deformity. And this is exactly the deformity, the mechanical axis. The people describe the deformity as a mechanical axis deviation. Is it just a mechanical axis deviation or more? You see here. It's worse. It's more than mechanical axis patients. You have crawling patients. It's not just a mechanical axis deviation. It's not just genoverum and genovalgum. Look to these deformities. How severe they are. Because if you look to the books talking about the deformity and the animations, they talk about the deformity at just 10 degrees varus and 5 degrees valgus. No, it's not like this. especially in our area. You see this patient with 180 degrees rotation of the foot. Look to this patient. You know, it's far worse than just mechanical axis deviation. And they call severe deformity can have consequences. No, it can be a very handicapping conditions. Look here to the crawling patient. You can have a crawling patient because of the deformity. What's the aim of the deformity correction? Again, look to the books and the literature. Aim of the deformity correction is to correct the mechanical axis. This is not true in my mind. It's more, we have to look to the depth of this subject. So if this is just correction or a malalignment correction, look to this patient with a valgus deformity who did osteotomy of the supracondylar femoral osteotomy, and we corrected the mechanical axis. It's not just like this. Look to this patient with such a deformity. Bedridden patient at age 5, and this is after treatment. Look at in adolescence. The aim of the deformity is not to have a mechanical axis. The aim of correction of the deformity is changing lives. You change the life of the patient from a bedridden patient to almost normal patient. What's the impact of this problem? A child with a deformity in Egypt or in the Middle East. It's a huge problem. Why? The children population in the Middle East is about 30% of the population. Look to Europe and the States, there is no comparison. The economic burden, the limited resources, psychological effects, and the society attitude to the deformity. So in the Middle East, more than 1/3 of the population is under the age 15. The growth rate is more than 33%. So we have a high incidence of deformities. Also the conflicts, the victims of the conflicts, we have too many of the victims of the conflicts. The second problem is the late presentation. You can have a patient presenting to you at the age 36 with this deformity on both sides, or 32 or 5. When you look to the treatment guidelines in Europe and the States, they talk about receiving the patient at birth. But there's nothing if you receive the patient at the age of 32 or 36. Very important subject is that amputation is not an acceptable way of treatment. So this patient, at this age, about 15, has 35 centimeter shortening and no prosthesis, used a wooden block. So amputation is not an option. In spite of all the Egyptians, the pharaohs, the first people who used this prosthesis for the big toe, in such a case. Second, the problem with the high ambitions of our patients. Our patients, they have high expectations. Another problem, when the surgeons want to treat the patient, they always look to the American and English literature. And they have basics. And look to this basic. If you have a non-functional foot in fibular hemilia, if you have less than 3 rays, you have to do amputation because it's non-functional foot. But look to this patient, an adolescent patient, and he has only 1 ray foot and deformed 1 ray foot. Look here to the deformed 1 ray foot. But look the way the patient walks. It's moving from hypothesis to reality. Why they put these instructions? Why they put these guidelines? Because their experience is very limited. The number of patients they have in congenital deformities are very limited, but they have to put guidelines. Again, they say because if you have one ray foot, the patient cannot have a shoe. ما يقدرش يمشي بجزمة. Look to the patient with the sports shoes. The way she runs. Look. She's running. So again, most of the guidelines in the Western world are hypothetical guidelines. We have many factors when you want to correct a deformity. You have a hardware and deformity correction. You can use internal fixation or external fixation. But each one has limitations. So if you want to use an internal fixation to correct supramaxillary, you should have to put a plate something. So you should consider the hardware consideration. Again, we look to the
دكتور جمال. دكتور جمال حضرتك معانا دلوقتي.
شغال؟
شغال دلوقتي. ممكن حضرتك تعمل شير سكرين تاني بعد اذنك؟
اوكي. اوكي.
ظهرت معانا. احنا وقفنا عند سلايد قبل ديت. ممكن حضرتك نرجع ولا حضرتك رجعت؟
اوكي. This slide؟
لا قبليها.
Okay. And we worked with the Taylor special frame. 2005 is the first publication, one of the first publications of Taylor special frame. We talk about the core or the apex of the deformity. This is the core is the intersection of the proximal axis and the distal axis of the bone. They meet in the obvious core. This is the first line of the proximal axis and the distal line of the distal axis. So you have two lines. The level of the core can be intra-articular, you see here, intra-articular in the joint itself, or metaphyseal here, or diaphyseal. So the cora or the apex of the deformity can be intra-articular, metaphyseal, or diaphyseal. Core also has to be which plane. So the coronal plane, you see the core and coronal plane, or sagittal plane, you have a lateral X-ray, or oblique plane. What's the oblique plane? If you have a deformity in the AP and lateral, that means this is oblique plane, not on the AP or the sagittal, in between. Again, what's the difference between the apex and the cora? This is the apex. When the proximal axis and the distal axis meet each other, this is the apex, 1 point. But the chora is an axis. This is. So we have the proximal axis of the bone from in the center and the distal axis. And they meet each other in this point. And along that point on the transverse line, transverse bisector line, this is chora, that's chora, this is chora. They are all choras along the transverse bisector line. Again, this is the transverse bisector line, and those are all choras. We can correct the deformity, acute correction, or gradual correction, or gradual and acute correction. Both are valid. It depends upon the clinical situation. In such a case, you have a valgus deformity and with acute correction using a plate, not external fixation. So you can use internal fixation to correct the deformity. Don't be dogmatic. You can use acute correction using external fixation. Look to this patient. You have a C-shaped deformity. And we did correction by 2 osteotomies. This is first osteotomy and this is second osteotomy. And we did acute correction using external fixation. So correction of the deformity can be acute. You can use internal fixation or external fixation or any combination, and can be gradual or both in the same patient. During correction of the deformity, there are precautions. You have to take care of the nerves, the vessels, muscles, tendons, fascia, ligaments, and the skin. You have to respect the soft tissue. It's very important. Look to this patient. We have a severe deformity of the proximal femur. Perhaps you have 2 cores. You see. What would you think? Do you correct this patient acute or gradual? This patient has a severe deformity and has 2 cores. If you have a severe deformity, it's preferable to do gradual correction. So if you look to the first look, you should do gradual correction of the deformity. But we did acute correction. Why? This patient had osteogenesis imperfecta. The diagnosis is very important. The clinical diagnosis is osteogenesis imperfecta. In osteogenesis imperfecta, we have lax soft tissues. So it allows you to do acute correction. So you don't have to do gradual correction. So we did acute correction. What changes our mind? What changed our minds? The clinical situation. So the clinical ground is very important when you do deformity correction. It is not just you draw lines. No, it's far more. Another aspect of deformity correction is closed reduction of fractures. Most of you think about fractures. If you have a child, you can do closed reduction, but if you have an adult, you have to do an open reduction. Why? Especially if it's neglected case, because of the soft tissue interposition, because sometimes severe shortening. But look to this patient. This is neglected fracture neck femur. He came after 35 days. We have severe shortening, about 12 centimeters. Soft tissue interposition. Can you imagine that this patient can reach that point with complete union and almost anatomical reduction with closed reduction only? And this is the real merit of gradual treatment using circular fixator. Many people think circular fixator, the external fixator means that you do reduction, then you put the frame. No. You can reduce the fracture after the operation, gradually 1 millimeter per day. You consider the fracture something like lengthening, and I will show an example. This patient presented to us after about 31 days after the operation. This was a firearm injury, and you have comminuted fracture of the distal femur, comminuted fracture of the proximal tibia, and immediate postoperative, this picture, immediate postoperative. You see, totally displaced fracture in the lateral plane and displaced in the coronal plane. postoperative. Is it a failure of reduction? No. We intended to do purely closed reduction. So thus we did corrected the problem. We did some distraction during the operation. Then after 3 days, we started to do translation. You see this translation 1 millimeter per day. 1 millimeter per day. You see gradual distraction 1 millimeter per day. Coronal plane translation. We did the translation configuration of the circular fixator or reserve fixator. We did the reduction. You see from this point, 1 millimeter coronal distraction to that point. Then we did compression. This is short oblique. If you do axial compression, we're going to have shortening. It's side-to-side compression. Then look to the lateral. We did distraction first. Then we pushed this distal fragment. We changed the construct 1 millimeter per day till we get overcorrection. Why we had overcorrection with this anterior translation? Because we want to get rid of soft tissue interposition. How to get rid of soft tissue interposition? You don't have to do overreduction. You don't have to. Gradual distraction and overcorrection. Then, you see, this is a magnified picture. We push this segment anteriorly, 1 millimeter per day, till we had overcorrection. After we had overcorrection, we treat it as a deformity. So we draw the axis of the proximal femur and the axis of the distal tibia, distal femur, and they meet each other in the apex of the deformity or the chora. This is the proximal axis, and this is the distal axis. They meet each other in the chora or apex of the deformity. Then we put hinges here and distraction on the concave side till we correct the deformity. And we had, you see, from this point to that point, anatomic reduction. It's not acceptable reduction. It's anatomical reduction, anatomical reduction. So you can have anatomical reduction of the fractures postoperatively without anesthesia, using the deformity principles. This is the real merit of the deformity correction. So deformity correction is not just drawing lines. Deformity correction is not just correcting the mechanical axis. As you see in the books, the Western books, they talk about how we correct this mechanical axis, how we draw lines. You see the anatomical reduction. This picture again. You see the displacement, the patient coming on 35 days or 5 weeks. See the severe displacement. Most of the people think that you have to do open reduction because of the soft tissue interposition and severe shortening. This is immediate postoperative. We did some distraction here. Then gradual reduction. You see gradual reduction in the AP till we attained almost anatomical reduction. Then in the lateral position, you see gradual reduction 1 millimeter per day till we get anatomical reduction. You see bone formation. Bone formation. Why? With gradual distraction, with gradual movement, we treat the fracture as a corticotomy, and there is a stimulation of the bone formation. You see the reduction, anatomic reduction and bone formation. And this is postoperatively. And this is follow-up. Look to the x-rays. Very good reduction. And again, you can do closed reduction in most of the fractures, especially the comminuted fracture, if you use the tactics of the external fixation. The problem with the external fixation, that most of the people who taught you external fixation or reserve system, they are doing only internal fixation. They teach you how to put the frame. بيعلموك ازاي تحط الفريم. But many of them, they don't have the experience how to manage later on. An example for deformity is tibial hemilia, complete absence of the tibia. In such a case, we have a bifid lower femur. We use 3 operative steps: gradual centralization using the fixator, centralization and casting, and the correction of the residual knee and ankle deformities using the fixator. We were the first to publish conservative treatment of tibial hemilia, 2005. This publication 15 years ago. Sometimes we do the stages together because we use gradual treatment. Like this patient, we used centralization, we put the frame on, we correct the knee and the ankle together. And this is how the patient moves afterwards, from a bedridden patient to a running patient.
دكتور جمال استاذن حضرتك، انا اسف المقاطعه.
اتفضل.
الفيديوهات بس مش شغاله كويس عشان خاطر حضرتك ما دوستش على اوبتمايز سكرين شيرنج وحضرتك بتعمل شيرنج. فهل ممكن نقفل الشيرنج ونفتح الشير من جديد وندوس اوبتمايز سكرين شيرنج؟
يعني ادوس ستوب شير؟
بالظبط كده.
اوكي.
شير سكرين.
ايوه.
اوبتمايز سكرين شيرنج، وهنلغي الاوديو، نلغي الكمبيوتر اوديو.
All right. Share. Okay. Do I continue now? كمل.
تمام، اسف للمقاطعه، اتفضل حضرتك. بس الفيديو اللي فات ما كانش واضح، يعني ما كانش شغال كويس.
And this is a case of achondroplasia. Presented to us at the age 18. We saw the patient at the age 10 and we advised her to do lengthening, but she went to Europe and they advised her not to do anything till the age 16, to give her, to ask her at this age about her opinion. We don't believe in this. We treat the patient from the age 5 anyhow, because she presented at the age 18 with the tibial lengthening for about 17 centimeter. You see here, this is how she swims and she walks. And then femoral lengthening for 12 or 13 centimeters. The way she squats, because people think that huge, because some people say that it's 20% or enough. This is not true. And then at the age 26, she came for humeral lengthening. We did humeral lengthening on both sides for 10 centimeters. And this is the picture. Now she can use the upper limb for perineal hygiene because it was too short. My current protocol of lengthening now, we use a transverse lengthening. We start from very young age. بنبتدي من سن 5-6 سنين. We did 5 centimeters. And we do over lengthening of the tibia to tighten the lateral ligament and to correct the varus deformity. And then we do femoral shortening at the age 9 to 12, 9 to 11, 9 to 12 centimeters. Then a second tibial lengthening bifocal, 9 to 12 centimeters. Then humeral lengthening at the age 15 to 16. So before the patient goes to the college or the university, he's normal, almost normal shape. بنخلص كل التطويلات قبل ما العيان تخش الجامعة، لأن كل المشاكل النفسية بتحصل في الجامعة. Another example of clinical implications of deformities. Look to this patient. The patient has amputated foot and the comminuted lower segment. And this is crush injury, which is typical indication for amputation. Anyhow, he was treated by resection. All this segment had been resected and we had more than 20 centimeter shortening. And he was treated in Kenya, elsewhere by replantation. Unfortunately enough, it worked out with them and they came to us with this picture. Non-union, deformity. If you draw the axes, we have a deformity. and shortening for 20 centimeters. We did resection of this part and the correction of deformities. So we added 2 centimeters. We have 22 centimeter shortening, and we did corticotomy, lengthening for 5 centimeters, 10 centimeters, 12, 22 centimeters. You see here. You can reach significant amount of lengthening. I don't believe in 20% rule, which the Europeans and the Americans, they created, depending upon experimental studies. This is not true. So you have complete union here and 22 centimeter lengthening. And you see the length on both sides. Upper extremity lengthening. There was a bad reputation of the upper extremity lengthening. The upper extremity lengthening bad reputation were based on the no experience rule. Because there are people, they did very small number of patients, so they had no experience, and they reported many complications. But actually, we didn't face these complications. Like this patient with radial club hand coming at age 13, and we did lengthening for more than 110% of the original length. You see the difference on both sides. Combined treatment. Sometimes, if you want to treat deformities, you have to do combined treatment. Not only one line of treatment, you can combine of them. You see such a case presented to Arch at the age 8.5 years with severe valgus deformity and severe shortening due to Olier's disease. First, we did corticotomy of the femur and tibia. We corrected the deformity and had 10 centimeter lengthening of the femur and 3 centimeter lengthening of the tibia. And the mechanical axis was correct. Everything was okay. With the follow-up, the patient started to have recurrence of the deformity. You see, severe valgus deformity again. And we drew the lines, we drew the mechanical axis from the center of the hip to the center of the ankle. It passes lateral to the center. That means the patient has a valgus deformity. Where that valgus deformity lies. Then we draw the mechanical axis of the femur from the center of the femur to the center of the knee and the center to the center. So actually it's mostly femoral deformity, but we have also a little tibial deformity. So we put 8-plate or guided growth principle to the lower femur and the upper tibia, and you see we had correction or overcorrection of the deformity. See the correction? It's even under overcorrection. Then we started to have valgus deformity, so we put guided growth principle to the ankle too. So we used 2 methods of correction. We used Elizarov external fixator and lengthening. Then we used the guided growth principle. Why not? So clinically, you have to judge the patient. You can use more than method. Then we were planning to have another lengthening after 3 years to correct the residual mechanical axis, residual shortening. But the patient had a fracture of the degenerate here with this deformity. So we decided to use this fracture as a closed corticotomy. Because if you have a fracture, closed fracture, that means it looks like a closed corticotomy. So we put the frame on, we corrected the deformity or the fracture, closed the reduction of the fracture. Then we waited for a couple of weeks. Then we started lengthening 1 millimeter per day. استخدمنا الفراكشر سايت as a corticotomy. Closed, مقفول. Blood supply كله موجود. Then we wait the waiting period for a couple of weeks, not 1 week, couple of weeks. Then we start gradual lengthening. So we reached about extra 6 centimeters and we corrected the deformity. You see the regenerate, very good regenerate, because it's closed corticotomy. This is the best type of corticotomy. So you can use the fracture as a corticotomy. This is the real merit of the use of external fixation. It's not the frame. It's the principle. Forget about the frame. The problem was teaching the external fixator that they teach you how to do the frame. مشكلة في الاكسترنال فيكسيتور او الازارف انه بيعلموك ازاي تحط الفريم. دي مش حقيقي، فريم حتة حديدة يا جماعة. It's a principle، المبادئ اللي انا بقولها. How to treat the patient in a closed manner. Not to do any overreduction or something. You see with the follow-up, lengthening, correction of the mechanical axis. Physiotherapy. Again, most of the teaching and the teaching principles in the books in Europe and the papers, you should have a center or specialized center and physiotherapists or something. What are you going to do with the patients coming from Aswan, from long distance, from Yemen? We teach the patients what to do. Look here, how the patient walks. We teach them how to walk, to go swimming, to use the computer. It's very important. Hospital stay, only 1 day. Or daycare patient. Why? To reduce the expenses. خلي العيان يخرج نفس اليوم من المستشفى، احنا ما بنعملش حاجه. واليوم اللي بعده. We want to reduce the expenses. Most of the patients with severe deformities, they have limited financial support to have to treat them. What about the single use for the fixator? No. We use the fixator forever. صدوا مرة 2 10. And you can use guided growth like this patient. And during removal, you can do osteotomy to correct the denutation. Again, it's a mixture between the guided growth and the osteotomy and the correction of the deformities. You see before with the severe deformity, varus and internal rotation, and this is afterwards. Because of guided growth principle, then we did osteotomy and acute correction. But what about if you have this problem? Cora away from the apex of the deformity, like this patient. This is the apparent cora, and this is the real cora. Or you have the cora outside the bone. Look here, if the chondroplasia, if you draw the axis of the proximal segment and the axis of the distal segment, they meet outside the bone. Here also, they meet outside the bone. You see in this patient, post-traumatic, with this severe varus deformity. And this is the apparent cora. This is the axis of the proximal segment and the axis of the distal segment. They meet in this apparent cora. Sorry, the lines are not correct here because of something in the computer. But they meet here. This is the real cora. And this is the apparent cora. دي الكرة اللي انت شايفها بعينيك. بس الكرة الحقيقية هي دي. الاثنين اكسيس دول لازم يتقابلوا في دي. So some cases you have uniapical deformity or multi-apical deformity. In uniapical deformity, you have 2 lines, and in multi-apical deformities, you should have a 3rd line. This is the proximal segment axis, distal segment axis, and this is the axis of the middle segment. So they meet in 2 cores. This is an example. See, post-traumatic C-shaped deformity. We have 2 cores. When the axes meet each other, they meet in the apparent core. So this is the apparent core. But when we draw the 3rd line of the 3rd segment, they meet in other 2 cores. So we correct from 2 osteotomies. So if you use 2 osteotomies, you can correct the deformities by 2 osteotomies. One osteotomy and two osteotomies. And two open wedges like this patient. See after the operation. Again, this is clinical implication. You see this deformity. It's post-traumatic deformity, and the patient is a bodybuilder. If you want to do open reduction, it's going to be heroic, severe bleeding. And you see the skin here. If you want to open the skin here, who's doing severe soft tissue, it's not going to unite. So we did two osteotomies and to correct the deformities away from the fracture site. This is real clinical implication. So finally, the deformity is not just correction of the mechanical axis. You have many clinical implications. If you want to correct a deformity, you have to think about the clinical situation, the many clinical considerations. Again, this is correction of the deformity, changing the life of the patient from this point, from crawling patient to that point, to a walking patient. This is my real conclusion. I don't have to talk more. Changing the life of the patient from this point to that point. Thank you.
دكتور جمال في questions and answers ممكن حضرتك تفتحها بعد إذنك؟
Yes. I'm looking for questions. This is question from Dr. Al-Amoudi. He's a friend of mine from Saudi. He's a real expert also in deformity correction. He's sending best regards for all of you. He talks about using Lazarov. I used to reduce, then convert to internal fixation because I have bad experience with joint stiffness. This is a good question. Dr. Amoudi said that he prefers after correction deformity to use internal fixation. The problem, I've been using that long time ago, but I have a real problem, deep infection. And if you have one case of deep infection, you are not going to repeat it again. And I had such a case. So I stopped using internal fixation. He's right, he said the problem with the joint stiffness, if you stay in the frame for such a long time, the possibility increases of joint stiffness. But I'm trying now to move the patient to do other tactics, but not use internal fixation. I use, and abroad they use a lot the internal fixation after some time, but I quit that. I don't know why. Perhaps in our area, because of the hot weather or something, the rate of infection is higher than normal. So that's why I don't use internal fixations. I hardly use it, and sometimes of refracture, but even in such a case, there must be a time between using the internal fixation and the external fixation. Another question. He's talking about a partial weight bearing after deformity correction, like knee valgus correction, or any deformity. Else, is that best for non-weight bearing still 6? No. Mostly, we don't believe in the non-weight bearing. We always talk about weight bearing, graduated weight bearing. That means 20% or more till we reach the point of full weight bearing in the frame. Weight bearing is very important. We use the Lazarov principles. You know, a Lazarov frame is inherently unstable. You know, the wires are stable in all directions except axial compression. So if the patient do weight bearing, this is very healthy. Weight bearing increases the rate of bone formation. So weight bearing is very essential. So we don't think that non-weight bearing there is a place for non-weight bearing. It has to be weight bearing, graduated weight bearing. Another questions, what about X-fix complications? How to decrease the rate? An important point. Why do people talk about the complications? And you look to the English literature, American literatures, complications. In another talk, I gave you an example. If you look at the surgical load, if you look at the total knee, for example, the people in the West, they always talk about the surgical load. It means if you do 50 cases per year, your complications are so and so. If you do 100 cases per year of total knee, your complications will be so and so. If you do more than 150, your complications are less and less. So the minimum was 50 cases per year. This is surgical load. But look to the external fixation. I give you an example before about tibial hemilia. A center presented cases of tibial hemilia. They presented 10 cases in 3 centers, done over 32 years. So the surgical load was 0.1 patient per year. خبرته بيعمل حالة كل 10 سنين وبدينا خبرته ويشرح لنا الكومبليكيشنز. So take care from the European and American literature about external fixations, because the number of patients they had are very minimal. You can take their experience from the animation. Most of the cases they present animations. We don't present animations. We have more than enough patients in our area not to present animations. So experience, that means what's meant by experience? The workshops are not enough. Workshops are just doing the plastic bone. You take the bone and do it this way, and you put the frame that way or something. No, the real experience comes from following the patients up. So you have to come to the outpatient clinic and see the patients and follow up the patients. This is how to listen or to decrease the number of complications. When doing double osteotomy, would you begin with both simultaneously or one another? No, I'll do it one another. I usually start from the proximal, then I go to the distal. So consequently, not at the same time. And each time I close the wound. I don't like keeping the wound open for some time. So we do the first corticotomy, close the wound, or I leave it to the assistant to close the wound. Then I go to the second osteotomy. Yes?
Oh.
How to detect CORA and its effect on open osteotomy? Simply, if you want to detect the CORA, you draw the axis, the mechanical or the anatomic axis. You align the axis in the center of the bone of the proximal segment, and they draw the axis of the distal segment. They are going to meet each other in the CORA or the apex of the deformity, simply. And simply, the rule number 1, and to do the osteotomy exactly at the CORA. This is number 1. This is very simple with the open osteotomy. The second rule, you can do the osteotomy not exactly at the CORA, because sometimes the CORA is intra-articular. And this way, they have to correct it with some displacement. The question is about technical consideration in every case very rapidly. Charcot joint and the role of Elizarov in management. This is very important topic. And very soon, I'm going to present a lecture. You have to wait for it, about Charcot joint. How to manage Charcot joint. And I will give you many examples. One example is to do resection, correct the deformity, and do compression distraction technique. Second example, we have an open wound infection. You resect the wound, you correct the deformity, and you have a gap, 6-7 centimeters. You do corticotomy up there, and you do bone transport. Another example, we have severe foot ulcerations, resistant to all types of treatment, and the patient had been advice for amputation for the vascular surgery. We do transverse bone transport. We do corticotomy of the medial part of the tibia, something like a piece of bone. Then after 10 days, we move this piece medially, 1 millimeter per day. It's called transverse bone transport to increase the blood supply. بزود البلد supply. Increasing the blood supply بيكمبات الانفكشن والونز بتقفل. بس انا اوعدكم في محاضره قريبا جدا هتبقى على الشاركوت جوينت. شاركوت بس. We have many cases. All the cases we have treated had been advised for amputation. كل الحالات اللي احنا عملناها كان القرار بتاع البلاستيك سيرجن والفاسكولار سيرجن ان هم يعملوا amputation. فانا اوعدكم في محاضره كامله على الموضوع. When to remove Elizarov after correction of the deformity? It's a good question. After correction of the deformity, we don't remove the frame directly. If you look to the frame and you decided to remove it, you loosen the nuts and let the patient walk for a couple of weeks. This will increase, because you do stabilize the frame, this will increase the regenerate. Then the final test, when you are in the clinic, outpatient clinic, you remove the rods. When you remove the rods, actually you remove the frame, but you kept the rods, everything otherwise. And you let the patient walk for 10 minutes, then get some rest for 10 minutes and so on. If everything is okay, you remove the frame afterwards. So you have to remove the frame gradually. Dr. Al-Amoudi again, my friend Dr. Al-Amoudi from Saudi, speaks about tibial hemilia. Do you apply femoral frame routinely and reconstructing the tibia? Yes. In type 1. In type 1 only we put the frame for the femur routinely. But in type 2 and the other types, no. Type 2 we don't. Another questions? Too many questions actually. Dr. Jamil. Yes. Do you think if you use distraction, the joint help for reduced joint stiffness? Dr. Jamil. Faqih from Riyadh. Distraction sometimes. We need distraction. Why? Because sometimes you have unstable joints. You know, many cases of tibial hemilia, femoral hemilia, they have unstable joints before the reconstruction. You have absent anterior crushing. You have lax posterior crunching. So you know from the start that you have an unstable joint. So I prefer in such cases to do crossover and you fix the other joint. Perhaps distraction in such cases can reduce the joint stiffness. However, in some cases, after I remove it, especially with long distances, you remove the frame, you have subluxation, and you have to apply the frame again. I think the principle of to get rid of the interposition of soft tissue needs more explanation. I agree with you entirely. Because I have a complete lecture, long lecture about closed reduction of adult fractures. Closed reduction of adult fracture is a new entity for the people. I agree with you entirely. Because most of the basics that we have learned, or you have learned too, about reduction of fractures in adults are taken from the AO group or the internal fixation group. And actually they talk about open reduction, internal fixation, or indirect reduction techniques. The indirect reduction techniques are totally different from what we explain here. And indirect reduction techniques, sometimes you do a small incision and you put bone levers and you use different tactics. But we speak about 100% closed reduction techniques. I will give some examples. You can reduce the fractures in the operating theater or in your outpatients. So the patient comes to you after 1 week of applying the frame. With this displacement, after 1 complete week, we started the reduction 1 millimeter per day. We have this, this overlap and soft tissue in between. What we do after the operation, we do distraction 1 millimeter per day, exactly like we do limb lengthening, exactly the same principles. We do 1 millimeter per day. So we did this way. When we do you see the soft tissue in between, when we get that point, the soft tissue is over there. Then we push this fragment that way, 1 millimeter per day. For overcorrection, why we do overcorrection? We displace it to the other side to get rid of the soft tissue, 1 millimeter per day. Then we correct it and we do closed anatomic reduction. So we get rid of the interpositional soft tissue by gradual distraction 1 millimeter per day. I promise you, there is another complete lecture. Perhaps you'll find it in that YouTube about closed reduction of adult fracture or closed reduction of distal femoral fractures without any incision. Another question. Tips and tricks for coronal translation by Elizarov. Yes. I've told you about coronal translation and sagittal translation. There are no tips and tricks. It's very simple. You have to learn just how to change the frame into a translational mode. So if you have a coronal, this is the translational mode. In my outpatient clinic, I don't do it. The nurses do it. It's very simple. It needs a simple-minded one, not a good surgeon or something. This is the translational mode in the coronal plane, and this is the translation mode in the sagittal plane. If you look to the cases, we put on the rings, we put, something like rods transverse, passing through posts, and to move transversely 1 millimeter per day. We move the nuts 1 millimeter per day. It's very simple, and there are no tips and tricks because it's quite simple. Second question. Thanks for sharing us this clinical experience. Do you think that deformity planning and drawing it is of value in the upper limb deformity? I'm going to speak about the upper limb lengthening and the lower and upper limb deformity on Thursday. I'm going to speak about the deformities of the humerus, and I have a publication 4 years ago about my experience with deformities of the humerus, and you will find it in the papers. And I'm going to explain on Thursday at 9 p.m. how to correct the deformities and lengthening of the humerus, forearm, and the phalanges too. The metacarpals and the phalanges too. We can do lengthening of them and correct the deformity of all of them. Drawing is less important in the upper limb than the lower limb. That's for sure. Role of Elizarov in trial of pseudoarthrosis tibia. This is, again, I'm going to present perhaps on Tuesday at 9 p.m. Elizarov in pseudoarthrosis tibia, my experience. What's new? By Elizarov, you can get the best results of union of pseudoarthrosis tibia, for sure. The real problem is with refracture. Elizarov did not solve the problem of reflection. How we solve it? I will show you an example, many examples in these lectures. All the cases now after we remove the frame. You know, most of the cases are distal with refractures. We put wires from distal to proximals. We put about 4 or 5 wires. What's the aim of the wires? We think putting the wires can stimulate the regenerate more. So it will increase the area or the blood supply of this area. Then we put the patient in a cast for an extra 4 months. We let the patient walk. And after 4 months, we change into another cast. And then the cast, we remove the wires. When you remove the wire, we stimulate the bone formation again. And then we let the patient in a cast for another 2 weeks. This extra procedures increases the bone formation. And for us, it makes, we don't have any refracture after we used this procedure. We're going to explain it on Thursday with a lecture at 9 p.m. about congenital pseudoarthrosis tibia. Dr. Walid Ali, if we have 20 centimeter lost tibia, what's better, fibular transfer procedure or segment transfer? Very good question. The best results are with tibial transfer. Why we do fibular transfer? In many cases, we have a special situation in the soft tissue. So if you move the fibula transversely, whether you do the whole fibula or a part of the fibula, sometimes use the whole fibula, or you do longitudinal dissection of the fibula, because you increase the blood supply. Sometimes the blood supply is poor. So when you do transverse distraction, the transverse distraction increases the blood supply of the fibula. How to judge the distraction, histogenesis rate, and the regenerate? Gradual correction needs patient compliance. How to deal with patient compliance? Okay. First questions. How to judge distraction osteogenesis? You have to judge distraction osteogenesis from the beginning. I've seen that before. Patient coming with the frame on after distraction for 10 centimeter, and the doctor told him, you don't have a regenerate, you have a problem, we have to abandon the procedures. No, you have to look for the regenerate after a couple of weeks from starting distraction. You have to. And within 3 weeks, if you don't see the regenerate, you have to slow down. You have to make it 0.5 millimeter per day. And you wait for 10 days. If you don't see the regenerate, you have to do compression. And if you do compression, you have to do compression 2 millimeters per day. Then, after you do 2 millimeters per day for 5 days, so if you did 10 millimeters, you wait for 3 days. Then you start the distraction again. If it's okay, you continue again with the same. If it's not that okay, you continue with the lesser amounts. It means 0.5 millimeter per day. There are no rules for the rate of distractions. Believe me, if you have tibial lengthening on both sides, perhaps the rate will be different on both sides. In congenital pseudoarthrosis tibia, and many times you have premature closure, you have premature maturation of the regenerate of the upper part. You have to take care. What about the patient compliance? I've met that, of course, but I don't meet it that often. Because when the patient come to my clinic, you see, many patients having the procedure. أنا بقنع العين إزاي؟ ما بقنعوش بالكلام الحقيقي، أنا بخليه يقعد بره في العيادة. يكلم الناس، كل العيانين مركبين. فبيشوف عشرات من العيانين. I give him some time to talk to the patients about the complications, how they suffer, the problems, and so on. This is the way to convince the patients. I know some patients, especially if they wait for 1.5 years in the frame, they have depression. And in our area, it's very difficult to convince the patient to go to a psychiatrist. So it's a real problem sometimes, but not very often with me. The question from Dr. Ismail Mansi: the role of biological elements like growth hormone in lengthening with surgery and short stature. Okay. He's talking about the Dr. Ismail ala the biologic treatment. This is the real advance. This is the real future. We are all dreaming about the biologic solutions. كلنا بنحلم على biologic solutions. This is the real dream. This is the real breakthrough. If you have a biologic solutions, but the biologic solutions are still infancy. We are dreaming about the growth factors, morphogenic proteins, cytokines, many factors, many players in the field, but still they are in the experimental phase. So we don't use them, not now, because when you use things on the clinical ground, we don't use experimental things. So in short statures, you know, we have a lecture on the YouTube about limb lengthening. I'm going to give you my experience, thousands of cases of limb lengthening. You see, we don't use experimental things in humans. So they are still in the infancy. I think now we finished most of the questions. There are too many questions. And I will leave the microphone to Hygiene Company. They are going to, I would like to thank them again for supporting me. شكرا على طبعا السبورت بتاعكم للجمعية وللأنشطة العلمية، ونتعشم طبعا ان انتم تسبورت اكتر واكتر في الفترة القادمة. انا عارف ان انتم عاملين جوائز، مش كده؟
مظبوط، في سكرين ان شاء الله هتبقى جايزه النهارده على اللي هيجاوب على ال3 questions اللي هيتحطوا.
امال ايه المليون جنيه اللي انا سمعتها دي؟
يا نهار ابيض. دي نيكست ان شاء الله باذن الله، الكومبيتيشن الجايه بقى.
اوكي اتفضل.
ميرسي دكتور جمال.
لا
طبعا بشكر دكتور جمال حسني على المحاضره الشيقه الجميله اللي قدمها لنا النهارده. طبعا ميني ثانكس طبعا للايجيبشن اورثوبيديك اسوشيشن على ان هم اتاحوا لنا الفرصه ان احنا نكون كشركه هايجيت متواجدين معاهم النهارده، وفي نفس الوقت طبعا على كل الاتنديز الموجودين على الويبينار دلوقتي. مع حضراتكم محمد فاروق، جروب برودكت مانجر شركه هايجين، وان شاء الله يعني 5 دقائق بالظبط هيكون باذن الله خلصنا وابتدينا الكومبيتيشن بتاعتنا بالاسئله، وان شاء الله يكون في فايزين باذن الله. هنقدم النهارده الحقيقه بريف سريع كده على البرودكتس بتاعتنا او البورتفوليو الخاص بالاورثوبيدكس، واحنا يهمنا الحقيقه فيهم 3 برودكتس. اول برودكت اللي هو التيجنت بلس، اتمنى بس ان هو يكون البرزنتيشن دلوقتي واضحه عندكم. سلايد. Is it okay? دلوقتي المفروض ان بس اتاكد ان البرزنتيشن موجوده عند حضراتكم. ابتدت تتعرض. هنقدم فيها برودكت شركه هايجين. شركه هايجين طبعا هي شركه مصريه بتابلاي التوب سيرفيس ستاندردز. الحقيقه الشركه بقى لها دلوقتي اكثر من 10 سنين في الماركت المصري، ويمكن في البورتفوليو بتاعنا الاورثوبيدكس يهمنا 3 برودكتس. البرودكت الاولاني فور مانجمنت اوف اوستيوارثرايتس اللي هو التيجنت بلس، هكلم حضراتكم عليه دلوقتي. وفي الحقيقه 2 برودكتس للبين مانجمنت اللي هو الفانتومور والريديوربان. انا بس هتاكد ان البرزنتيشن دلوقتي موجوده عند حضراتكم. موجوده. سلايد شير اشتغل كده.
دكتور محمد السلايد شير شغاله كويس واحنا شايفين المحاضره بتاعتك.
تمام اوكي تمام ميرسي. اوكي التيجنت بلس طبعا هو عباره عن برودكت يونيك فورمولا لعلاج الاوستيوارثرايتس. الانجريدينتس بتاعنا بتكون 5 مين انجريدينتس اللي هو الكولاجين واللاكتوفيرين المايكرولاكتين الكوليسترول الفيتامين سي. طبعا يمكن معظم حالات الاوستيوارثرايتس اللي هتقابل حضراتكم بيبقى عندنا فيه 4 مين اوبستكلز في المانجمنت. البين اللي بيبقى البيشنت دايما بيجي يشتكي منه، الانفلاماتوري بروسيس اللي بتحصل during الكارتلج بريك داون، وكمان الاوكسيديتيف دامج اللي بيطلع فري راديكلز او اوكسيديتيف رياكتيف سبيشيز بتطلع تزود لنا الدامج اللي بيحصل في الكارتلج والكوندروسايتس. التيجنت بلس هو عباره عن يونيك انوفيتيف فورمولا ليه باورفول انفلاماتوري ميديوليتور افكت، كونتر بروتكتيف وانتي اوكسيدانت افكت. الحقيقه الثلاثه دول مع بعض، الانفلاماتوري ميديوليتور افكت، الكونتر بروتكتيف، الانتي اوكسيدانت افكت، بينشور سيجنيفيكانت امبروفمنت في كل الساينس والسيمبتومز بتاعت اوستيوارثرايتس عن طريق ان هو بيعمل ريديوسنج للجوينت بين والستيفنس بشكل واضح جدا، وفي نفس الوقت بيحسن من الجوينت هيلث والكواليتي اوف لايف بجارانتيد طبعا توب سويس ستاندردز اللي بتقدمها شركه هايجن. التيجنت بلس زي ما قلت لحضراتكم هو عباره عن يونيك فورمولا، يمكن هو البرودكت الوحيد في الايجيبشن ماركت اللي بيبقى فيه الفايف مين انجريدينتس دول، اللي هم الكولاجين، اللاكتوفيرين، والمايكرولاكتين. يمكن دي حاجه يونيك، المايكرولاكتين مش موجوده يمكن غير في التيجنت بلس، والكولوستروم والفيتامين سي. سريعا جدا هنتكلم عن الانجريدينتس. يمكن حضراتكم طبعا عارفين الكولاجين بشكل كويس جدا. الكولاجين ليه دور مهم جدا، هو عشان خاطر بيعمل اكيوميليشن في الجوينت او في الكارتريج، وفي نفس الوقت هو بروتين مهم جدا بيكون لنا الاكسترا سيلولار ماتريكس بتاعه الكارتريج. طبعا استخدام الكولاجين وجدوا ان هو طبعا بيقلل بشكل كبير جدا البين والستيفنس وفي نفس الوقت الانفلاميشن. الكولاجين الموجود في التيشنت بلس هو مارين كولاجين، وده يمكن بيتميز بالبايو افيلابيلتي بتاعته العاليه قوي، فبالتالي الابزوربشن بتاعه بنضمن ان هو بيكون عالي، البايو افيلابيلتي عاليه، وبيوصل ريتش للجوينت بكونسنتريشن عالي. تاني انجريدينت معانا هو اللاكتوفيرين، ودي يمكن من الحاجات اليونيك اللي موجوده في التيجنت بلس. يمكن حاجات كتيره في الماركت فيها كولاجين، لكن اللاكتوفيرين يمكن يونيك، وكنا احنا مقدمينه لحضراتكم قبل كده في برودكت البرافوتين. اللاكتوفيرين طبعا هو مالتي فانكشنال بروتين. يمكن اللاكتوفيرين ليه 4 مين فانكشنز بيهمونا جدا في المانجمنت اوف اوستيوارثرايتس. اول حاجه دي اللي هي الانفلاماتوري موديوليتور افكت. طبعا الانفلاماتوري ميديوليتور افكت ده بيقلل لنا الانفلاميشن اللي بيحصل عن طريق ان هو بيعمل انهبيشن لمجموعه كبيره جدا من الانفلاماتوري ميديوليتورز لايك الانترلوكين 1 بيتا، التي ان اف الفا، الانترلوكين 6. مش بس الحقيقه بيعمل انهبيشن للانفلاماتوري ميديوليتورز دول او الانفلاماتوري ميدياتورز، لكن كمان بيعمل ستيميوليشن لانتي انفلاماتوري ميدياتور مهم جدا اللي هو الانترلوكين 10 اللي بيانتاجونايز الاكشن بتاعه التي ان اف الفا وبيبروموت الكولاجين فورميشن. فده بالنسبه على ليفل الانفلاميشن زي ما قلت لحضراتكم هو ليه انفلاماتوري ميدياتور افكت قوي جدا، بلس ان هو ليه كونترو بروتكتيف افكت، وبيعملهم بثلاثه ميكانيزمز اوف اكشن. اول حاجه ان هو ليه انتي كاتابوليك افكت عن طريق انه بيقلل الريليز بتاع البروتييزز زي الماتريكس ميتال بروتييزز، وبالتالي بيقلل بشكل كبير جدا من الديجراديشن والديجنريشن اللي بيحصل في الكارتريج. بلس ان هو ليه انابوليك افكت بيحسن جدا من الكوندروسايت بروليفريشن، وفي نفس الوقت كمان بيقلل من الابوبتوزس انتي ابوبتيك افكت، وبالتالي بيدينا في الاجمالي كونتر بروتكتيف افكت فبيمنع الكارتريج بريك داون. بلس ان هو ليه دور مهم جدا في عمليه البين ريدكشن لان هو بيشتغل على السايكلوكسينيز انزيم، وبالتالي بيقلل من البرودكشن بتاع البروستاجلاندين اي 2، فبالتالي بيدينا سيرجستيك افكت مع الان اس ايدز لو احنا بنستخدم ان اس ايدز او انالجيسكس علشان خاطر نقلل البين، وبالتالي بيقلل بشكل كبير جدا البين اللي بيبقى مصاحب للاوستيوارثرايتس. اخر حاجه ودي مميزه جدا في اللاكتوفيرين ان هو ليه انتي اوكسيدانت افكت. الانتي اوكسيدانت افكت اللي بيقدمه هو عن طريق بيعمل تو ميكانيزمز اوف اكشن. اول حاجه ان هو بيمنع البرودكشن بتاع الهيدروكسيل راديكالز عن طريق ان هو بيعمل سكافنجنج للفري ايرن لان هو ليه باور عاليه جدا عشان يسكافنج الايرن، وبالتالي بيمنع الاكسيداتيف دامج اللي بيحصل من الهيدروكسيل راديكالز. بلس ان هو بيعمل انهبيشن للانديوسبل نيتريك اوكسيد سينثيز، وبالتالي بيقلل من البرودكشن بتاع النيتريك اوكسيد واحده من الفري راديكالز بتسبب لنا الدامج اللي بيحصل في الكوندروسايت، وبالتالي بيقلل بشكل كبير جدا من الاكسيداتيف دامج اللي بيزود من الديجري اوف بريكنج داون للكارتريج. اليونيك عندنا اللي بنقدمه يمكن ومش موجود في اي برودكت تاني في الايجيبشن ماركت هو ماده المايكرولاكتين. يمكن المايكرولاكتين موجود بره كبراند باسم مايكرولاكتين، احنا هو انجريدينت عندنا موجود في التيجنت بلس. المايكرولاكتين هو عباره عن بروتين كونسنتريت بيبقى واخدين من هايبر امينايزد كاو، يعني هو هايبر امينايزد ميلك بروتين كونسنتريت بيحتوي على نسبه عاليه جدا من الهاي موليكولار ويت اميونوجلوبولينز واللو موليكولار ويت بايو اكتيفز. الحقيقه دول بيدونا بوتنت انتي انفلاماتوري افكت قوي جدا عن طريق ان هو بيعملوا انهبيشن للمايجريشن اوف نيوتروفيلز للسايت اوف انفلاميشن، وبالتالي الريليز بتاع السيتوكاينز اللي بتزود لي الديجري اوف انفلاميشن. وعشان كده لما هو بيقلل الانفلاميشن ده بشكل سيجنيفيكانت جدا البين بيحصل له ريدكشن بشكل سريع، وزين 2 ويكس بيبتدي البيشنت يتحسن او بيحس بتحسن بشكل كبير جدا لان الانفلاميشن بيبتدي يقل، وكمان البين والستيفنس بيبتدي يقل بشكل كبير جدا، فبيبتدي البيشنت يتحسن بشكل سيجنيفيكانت مع استخدام المايكرولاكتين اللي هو عباره عن انجريدينت جوه التيجنت بلس. يمكن دي استادي كانت معموله سنه 2002 في الكرنت ثيرابيوتيك ريسيرش في USA، واللي كانت بتاكد فعلا ان استخدام المايكرولاكتين within 6 weeks كان ليه better effect يمكن مور ذان الجلوكوزامين. في الجروب اللي استخدم الجلوكوزامين يمكن كان ليه better effect على مستوى الووميك سكيل، ايذر على البين ريدكشن او الستيفنس او على الفيزيكال فانكشن. كان واضح جدا ان التحسن ابتدى حتى يظهر بشكل سيجنيفيكانت جدا من الويك 2 فيرسس الجلوكوزامين، وطبعا اكيد الاثنين كانوا افضل من البلاسيبو. رابع انجريدينت معانا هو الكوليسترول، والكوليسترول الحقيقه بيحتوي على مجموعه كبيره جدا من الانتي انفلاماتوري بروتينز اللي بتقلل بشكل كبير جدا الانفلاماتوري بروسيس اللي بتحصل، بلس ان هو في مجموعه كبيره جدا من الجروث فاكتورز. الجروث فاكتورز دي الحقيقه هتهمنا عشان خاطر بتعمل ريجوفينيشن تاني للخلايا وريبيرنج تاني للخلايا، والحقيقه كمان بتدينا اد اون بنفيت. بالنسبه لمعظم البيشنتس اللي بيستخدموا ان اس ايدز بيحصل عندهم جات دامج، دي بي بشكل كبير جدا الجات دامج اللي بيحصل، فبتدينا اد اون بنفيت للبيشنتس دول اللي بيستخدموا النون ستيرويدال انتي انفلاماتوري، فبشكل كبير جدا بتحسن من الحالات دي. اخر حاجه طبعا في او الانجريدينت الاخير هو الفيتامين سي، والفيتامين سي طبعا زي ما حضراتكم عارفين دوره ان هو بيبوست الكولاجين سينثيز والستورج، بلس كمان ان هو بيقلل بشكل كبير جدا لان هو انتي اوكسيدنت الاوكسيديتيف ستريس او الاوكسيديتيف دامج اللي بيحصل، وبالتالي بيقلل من معدل الكارتريج بريك داون اللي بيحصل نتيجه الاوكسيديتيف دامج. دول الحقيقه الفايف مين انجريدينتس اللي موجودين، زي ما قلت لحضراتكم حاجه يونيك موجوده في التيجنت بلس، مش موجوده في اي برودكت ثاني في الايجيبشن ماركت بتقدمه لكم طبعا شركه هايجنت. الخمسه انجريدينتس دول بيعملوا لنا مانجمنت بشكل هايل جدا لكل الساينس والسيمبتومز بتاعت الارثرايتس، عن طريق ان هم ليهم بوتنت انفلاماتوري ميديوليتور افكت، بيمنعوا البرو انفلاماتوري ميدياتورز زي الانترلوكين 1 بيتا، الانترلوكين 6، التي نيف الفا، بيستيميوليت الانتي انفلاماتوري ميدياتورز لايك الانترلوكين 10، وبالتالي انا مش بس بقلل الانفلاماتوري ميدياتورز، لا ده انا بزود الانتي انفلاماتوري ميدياتورز او السيتوكاينز. ليه كمان باورفول كونتر بروتكتيف افكت عن طريق ان هو بيروموت الاكسترا سيلولار ماتريكس سينثيز ايذر باللاكتوفيرين او بالكولاجين نفسه اند بريفنتنج الكارتريج بريك داون. ليه باورفول انابوليك وريجوفينيتيف افكت على الكارتريج، وليه كمان significant effect على الريدكشن اوف البين والستيفنس واللي بيحس بيهم البيشنت بشكل سريع جدا مع استخدام التيجنت بلس وزين 2 ويكس بيبتدي يتحسن او بيحس تحسن بشكل كبير جدا. بلس ان هو طبعا ليه بوتنت انتي اوكسيدنت افكت لوجود اللاكتوفيرين ووجود الفيتامين سي اللي بيقلل لنا بشكل كبير جدا الاوكسيديتيف دامج اللي بيحصل، وطبعا بيزود لنا الكارتريج بريك داون. اخر حاجه زي ما قلت لحضراتكم من الاد اون بنفيت بتاعت الكوليسترول ان هو بيمنع لنا الجات دامج اللي بيحصل نتيجه استخدام ال اس ايدز مع الكونتر بروتكتيفز بشكل عام. ده الكونكلوجن عن التيجنت بلس. طبعا التيجنت بلس احنا بنقدمه في شكل ساشيتس، الباك عباره عن 10 ساشيتس بتتاخد 1 ساشيت بير داي قبل الاكل بربع ساعه او بنص ساعه، وهو طعمه بلاتابل جدا بالنسبه للبيشنت، هو طعمه بالاورنج فليفر. فبالنسبه للكومبلاينس بتاع البيشنت، وده يمكن حاجه تهم حضراتكم بشكل كبير جدا، اعتقد ان الكومبلاينس بتاعه هيكون عالي جدا والبيشنت هيفضل طعمه ويحب طعمه فيقدر ان هو يستمر عليه لفتره. تاني حاجه اللي هو احنا كده بالنسبه للتيجنت بلس خلصناه. البين مانجمنت، ودي حاجه سريعه جدا، احنا عندنا حاجه 2 برودكتس يهمونا جدا في البين مانجمنت كنون ستيرويدال انتي انفلاماتوري، ايزر بقى طبعا في حالات الاكيوت او الكرونيك بين او الكومبايند اكيوت ويز كرونيك. بنبتدي بالاكيوت بين، عندنا برودكت مهم جدا وهو الفانتومور. الفانتومور طبعا عباره عن ديكلوفيناك صوديوم 50 مللي جرام. الجديد اللي احنا بنقدمه في الفانتومور ان هو مش تابلت عادي، هو ديسبيرسبل تابلت. الديسبيرسبل تابلت طبعا مع وجود الديكلوفيناك صوديوم بيقدم لنا ميزه مهمه جدا اللي هو ان السوليبيليتي بتاعته تبقى اسرع، وبالتالي بيدينا فاست اونست اوف اكشن وزين من 10 ل 15 مينتس، بيبتدي البيشنت يحس بالانرجيستيك افكت بتاعه. وفي نفس الوقت كمان هو عشان صوديوم فبالتالي الريليز بتاعه بيبقى اقل شويه من البوتاسيوم، فبيبقى ليه لونجر ديوريشن. طبعا بنقدمه بالتوب سيرفيس ستاندرد بتاعت هايجن. لو عندنا كرونيك بقى بينفول كونديشنز ومحتاجين انتي انفلاماتوري يكون دي تولرابيلتي اعلى شويه ونقدر نستخدمه فتره اطول شويه، بنقدم طبعا الايديوروبان. الايديوروبان هو عباره عن لورنوكس كام 8 مللي جرام. الايديوروبان طبعا زي ما حضراتكم عارفين هو بوتنت انتي انفلاماتوري انتي ريوماتيك وانالجيسيك، وفي نفس الوقت التولرابيلتي بتاعته عاليه جدا لو انا هستخدمه فتره اطول شويه، لان دي بالانسد سايكل اوكسجينيز 1 و 2 انهبيشن، وبالتالي بيزود من التولرابيلتي بتاعته ما بيميلش ناحيه سايد افكتس خاصه بالكوكس 1 او الكوكس 2، بلس ان هو ليه شورتر هاف لايف تايم، وبالتالي دي بتدينا ميزه الحقيقه عن اقرانه من الاوكسيكامز اللي هو الميلوكسيكام او البايروكسيكام او التينوكسيكام، ان هو ما بيحصلوش كوميولاتيف افكت في الجسم، وبالتالي بيبقى ليه مور سايد افكتس. هو الحقيقه ما فيهوش المشكله دي خالص، بلس ان هو ليه الحقيقه سيفتي عاليه جدا مع الرينال والهيباتيك بيشنتس، ان هو ليه دول باس واي في الاكسكريشن بتاعه، فانا اقدر ادير هيباتيك بيشنت وانا مش قلقان ان هو يحصل له كوميولاتيف افكت او حاجه او سايد افكتس، ودي يمكن حاجه مميزه جدا في الديوروبان. الدوز طبعا بتاعته بيتاخد انيشال دوز 2 تابلتس، وبعد كده ب 12 ساعه بندي انذر تابلت. طبعا التابلت بعد كده بتبقى كل 12 ساعه يعني توايس ديلي. كده يبقى احنا عملنا كنترول ايذر للاكيوت بين او الاكيوت بينفول كونديشنز بالفانتومور والكرونيك بينفول كونديشنز بالايديوروبان. لو احنا عندنا كومبايند بين ممكن نستارت ويز فانتومور في الاكيوت بينفول كونديشنز ومينتين بالايديوروبان. في الكرونيك بين لايك الاوسترسرايتس ممكن نستخدم الايديوروبان، هنا تكون التوليرابيلتي بتاعته كويسه وفي نفس الوقت الافكاسي بتاعه هيكون عالي جدا. كده يبقى احنا قدمنا لحضراتكم النهارده 3 برودكتس تيجنت بلس فور مانجمنت اوف اوسترسرايتس. لو عندنا بينفول كونديشنز عندنا فانتومور فور اكيوت بين اند الايديوروبان فور كرونيك بين. بشكر حضراتكم جدا وكل سنه طبعا وحضراتكم طيبين. ودلوقتي هنانونس عن الاسئله اللي هي الثلاثه اللي ان شاء الله هيجاوب عليها هيبقى ليه هديه سكرين كبيره قوي ب1,000,000 جنيه بتاعت دكتور جمال، هيبقى ياخدها النهارده ان شاء الله. وهنعلن عن الفايز على الصفحه بتاعه الاي يو اي اللي هي الايجيبشن اورثوبيديك اسوشيشن نيوز، وكمان صفحه التيجنت بلس بيج بتاعه الفيسبوك باذن الله اللي هيستلم الجائزه وهي هتوصل لحد عنده يعني. فهنبتدي دلوقتي بالاسئله. السؤال الاول: correction of the deformity can be acute or gradual or both. Yes or no؟ ده السؤال الاول اللي هيجاوب يختار yes or no. السؤال الثاني: Teagent Plus is unique because it is the only product that contains 5 active ingredients اللي هو الكولاجين، لاكتوفيرين، مايكرولاكتين، كولوسترم and فيتامين سي. Yes or no؟ اللي بيجاوب يختار yes or no. Finally السؤال الثالث: Teagent Plus for osteoarthritis acts only as chondroprotective. Teagent Plus for osteoarthritis acts only as chondroprotective. Yes or no؟ دول الثلاث اسئله حضراتكم هتجاوب عليهم، وان شاء الله هيكون في درو على سكرين LED هتكون ان شاء الله الجائزه، وهيعلن اسم ان شاء الله الدكتور الفائز على البيج بتاعه اليو اي نيوز وبيج تيجنت بلس. بشكر حضراتكم جدا وكل سنه وحضراتكم طيبين، ويا رب دايما ان شاء الله كده متجمعين دايما. بشكر جدا جدا دكتور جمال تعبناك معانا. بشكر طبعا كل اللي قائمين على العمل النهارده من منظمين، وبشكر طبعا الجمعيه. اتمنى ان شاء الله ان احنا دايما نكون متواجدين معاكم، ودايما باذن الله يعني تكون شركه هايجنت متواجده بشكل مستمر باذن الله مع الايجيبشن اورثوبيديك اسوشيشن ان شاء الله.